Hello and welcome back to the Academy of Anaesthesia. This week we're going to talk about the pharmacology of anticholinesterases. They come up frequently in the Primary FRCA and unfortunately do make a return in the final, albeit briefly. We'll first quickly go over how anticholinesterases work, then we'll discuss the classification system of the drugs, and finish off by reviewing organophosphate or nerve agent poisonings and their management. There's a fair bit of chemistry in this video, so brace yourself as we go through how these drugs work. A brief recap of the physiology. The neurotransmitter acetylcholine is released into the synapse where it acts on nicotinic or muscarinic receptors. Once the transmission of this signal is complete, acetylcholine is rapidly broken down by acetylcholinesterase in the synapse. Imagine this enzyme as a W. There are two sites, an anionic binding site and an esteratic binding site. If we go back to the structure of acetylcholine, which thankfully you don't need to memorize for the exam, the choline part has a quaternary amine group. Quaternary amine is a fancy way of saying it has a nitrogen atom which has 4 bonds, and so it's positively charged permanently. The other end has an ester group, which is a COOR group in the molecule. And so they fit nicely together where the anionic site of the enzyme attracts the positively charged nitrogen and the COOR group binds to the esteratic site and undergoes the hydrolysis part of the reaction. The hydrolysis of acetylcholine produces choline and acetic acid. Choline is reabsorbed into the presynaptic nerve and recycled. This process also happens in various other parts of the body, including the synapses between parasympathetic nerves and muscarinic receptors. And so inhibition of this enzyme will have effects there too. And so all the drugs within the anticholinesterase group will have muscarinic side effects to some degree. Moving on to the drugs themselves, anticholinesterases, also known as acetylcholinesterase inhibitors, are drugs that mainly inhibit the enzyme acetylcholinesterase. If you stop this enzyme from working, more acetylcholine is left in the synapse and so leads to increased cholinergic activity. Acetylcholinesterase inhibitors mainly work by binding to the esteratic site and forming compounds. The stability of the compound formed is correlated to the duration of action, i.e., if the compound formed is very stable, the duration of action is much longer, as it takes a long time for the enzyme to break away and free up. So the classification system most commonly used is according to the duration of action, or the stability of the compound. There are 3 main classes: short-acting, medium-acting and long-acting. Short-acting drugs mainly include edrophonium. Its use has been largely discontinued, and so I'll just mention briefly that it forms a very weak bond and so is easily reversed. Therefore, the duration of action is only 10 minutes. This is the reason why the drug was historically used to perform the tensilon test in the diagnosis of myasthenia gravis. In the medium-acting category, you have the stigmines, and in order of duration of action, from shortest to longest, you have neostigmine, pyridostigmine, and physostigmine. This category of drugs form what is known as a carbamylated enzyme complex. This essentially means that the drug forms a very stable but reversible bond within the enzyme. Acetylcholinesterase will eventually break away from the compound, but it just takes a long time to do so. Both neostigmine and pyridostigmine are quaternary amines, whereas physostigmine is a tertiary amine and so has different properties. Because it's not ionized, it's able to cross the blood-brain barrier due to its increased lipid solubility. Neostigmine is the most important one here for us anaesthetists. It's the one you should know about as it's used in anaesthesia and ICU. I'm not going to read out the numbers as it's not a good use of your time. That information is readily available in any pharmacology textbook, but the key unique features of neostigmine are as follows. When used in ICU, it's used for refractory constipation, and the aim is to increase acetylcholine availability at the myenteric plexus in the gut. It also inhibits pseudocholinesterase and so will prolong the effects of drugs that are broken down by this enzyme group, such as succinylmethonium. When it's used for the reversal of neuromuscular blockade, it's also given with glycopyrrolate to counter the muscarinic effects. Glycopyrrolate shares a similarity with the chemical structure of neostigmine in that it's also a quaternary amine, and therefore it's ionized, and it also doesn't cross the blood-brain barrier. Just briefly touching on the other two, pyridostigmine is used in myasthenia gravis due to its longer duration of action of approximately 3 to 6 hours. Physostigmine has been classically used in the treatment of anticholinergic toxicity and glaucoma. This table is from a British Journal of Anaesthesia article, which I've referenced below. and helps you compare neostigmine with other anticholinesterases. I wouldn't bother learning the individual values, but it's important to at least be aware of the differences in the duration of action. Pause the video and see for yourself. Finally, the longest acting drugs are the organophosphate compounds or the nerve agents. These poisons create a covalent bond with the enzyme by phosphorylating the esteratic site. If you remember from your high school chemistry, these bonds are extremely strong and stable. If the enzyme is left long enough, the chemical structure of the compound will change and become irreversible. This is a process known as aging. One of the only ways to increase acetylcholinesterase activity levels back to normal is to make new enzymes, which takes a long time. This next part is a more detailed discussion about organophosphate or nerve agent poisonings. Most of this information is too deep for the exam, but the things to remember will be how to recognize organophosphate poisoning and the key principles of the management, as this could come up as part of a clinical question or in the final viva. The classic question stem is usually a farmer who has been exposed to pesticides which contain organophosphate compounds. To add a bit more context, many will remember that the poisonings in Salisbury in 2018 used an agent called Novichok, which is in fact an organophosphate compound. If acetylcholine is released at the neuromuscular junction and then cannot be broken down, the receptors remain in a state of activation, which leads to an effect not too dissimilar from succinylcholine in that it gives you a depolarizing paralysis. They can be absorbed through the skin as they are highly lipid soluble and can rapidly cause lots of side effects, with the main cause of death being respiratory arrest, leading to cardiac arrest. Because of their increased lipid solubility and high volatility, nerve agents and organophosphate compounds will be rapidly absorbed by the eyes, lungs and skin, and so most, if not all patients with significant poisoning will present with meiosis and increased secretions. If enough absorption has occurred, the patient will go on to develop systemic side effects. To remember the most important side effects, you can remember the 3 Bs. The 3 Bs are bradycardia, bronchospasm and bronchuria, or respiratory secretions. When discussing the management of a complication or condition in the final FRCA, you should classify it into general management and specific management. General management is mostly the supportive steps you perform for almost any acutely unwell patient, which includes the ABCDE approach. Specific management is tailored to the condition being encountered. And so for organophosphate or nerve agent poisoning, the specific management would include removal of contaminated clothing and the 3 key principles of treatment, which are antimuscarinics, oximes, and neuroprotection or anticonvulsants. The antimuscarinic of choice is atropine because it crosses the blood-brain barrier and is able to block the activation of muscarinic receptors from the increased acetylcholine in the body. These patients need shed loads of atropine, and just to give you an idea, the UK military and NATO have a protocol of giving an initial bolus of 5 to 10 milligrams of atropine for severely poisoned patients. You heard me right, 5 to 10 milligrams. This can be repeated every 5 minutes until a reversal of the 3 Bs has occurred. There are other dosing regimes also published, and so it's best to contact the National Poisons Information Service if you're in the UK to get specific guidance. Oximes such as pralidoxime work by reactivating the acetylcholinesterase enzyme before the aging process occurs. They have varied effects and depend on what specific oxime is used, the type of nerve agent, whether the enzyme has aged, and other factors. Therefore, oximes are best given as early as possible before the enzyme has had a chance to undergo aging. Due to the increased cholinergic activity in the central nervous system, there is an increased risk of seizures, and so anticonvulsant use and neuroprotection may be necessary. Another practical point is that if the patient needs intubating, these poisons can contaminate the anaesthetic machine and the circuit. A BJ review on this topic recommends using a dedicated machine if possible, which should undergo decontamination protocols before being used on other patients. And that's all you need to know to be able to classify and discuss acetylcholinesterase inhibitors in the viva. To summarise, we have discussed the structure of the acetylcholinesterase enzyme and the physiology. We briefly touched upon the pharmacology of the acetylcholinesterase inhibitors. When revising for the primary FRCA, the pharmacology of neostigmine is the one you should focus most on. And we finished off by discussing how to recognise and the key principles of the management of organophosphate or nerve agent poisoning. If you remember the structure of the drug as a double triangle which fits into a W, it might help you remember the two triads for the recognition and the management of organophosphate poisoning. The extra details I've added are just out of interest and to add some context to what can seem like abstract information. As usual, all the references I've used are linked in the video description below. I hope you found the video useful, and thank you very much for watching.